We are back on Taking Care of Business on Koerner Radio, News Talk 1180, 1230 KGEO, and 1410 KERI. Our guests by phone, John Nelson, President of Warner Pacific Group, and Mike Belote, Consultant to California Health Underwriting Association, talking about Obamacare.
Actually, Mike, I think you're the lobbyist for the association. Is that correct?
Well, that's the commonly accepted term, consultant, lobbyist, representative, you name it.
And you represent several groups in Sacramento.
We are a contract lobbying firm. We have had the pleasure of representing the California Association of Health Underwriters, but yes, I represent other interests as well.
And are those other interests interested in this health care bill, do you think?
Not to the extent the health underwriters are. So no, not really.
Well, one of the things that the bill brings into place, and John keeps saying the ACA, and that's actually the Affordable Care Act, formerly known as the Patient Protection and Affordable Care Act, which I've renamed as the Unaffordable Care Act. So, John, one of the things that they're talking about bringing into play are exchanges. Can you talk a little bit about what an exchange is and how it will work, and will insurance agents be participating?
Well, the idea, generally speaking, about exchanges, first of all, exchanges would apply to both small group as well as individuals. And Congress's intent here in developing the exchanges was to develop a shopping center of sorts for individuals who are applying for coverage, that they can go online and regardless of whether they're employed or they're just unemployed or they're self-employed, that they can get an option of have an option of insurance companies to choose from as well as products, and hit the apply button and get their coverage. So that's the purpose, that's the idea of the exchanges. On the group side, there's some question about the level of demand for that kind of thing. A lot of employers already have that kind of choice available to them via the insurance companies. Insurance companies have anywhere from 2 dozen to 3 dozen options for employees of a given employer to choose from, and it's a very simple process for employers to go with one insurance company and have those options for their employees rather than introduce additional options. So there's a lot of folks, including on the state and federal side, that question the amount of demand for that type of product. On the individual side, that's where the action is going to take place, because within the ACA, there is a provision in there that provides subsidies for people who cannot afford coverage. And anybody who receives a subsidy has to buy their coverage through the individual exchange. And so the bulk of the membership that either of these exchanges see will be through the individual side. Now, having said that, we still have the problems of the individual market that I referred to earlier. You're going to have an adverse selection market. The bulk of these people who buy coverage inside the exchange are going to be previously uninsured. So that's the good thing. They're going to get insurance for the first time. But the thing that's going to put pressure on the system is the fact that they have insurance for the first time, and they may have pent-up medical needs that they're going to need to have paid for. And so that's going to hurt the insurers even more on top of the ACA-related pressures I referred to earlier.
And I think a fascinating cultural shift is going to occur. You have literally millions of people who, as John indicated, in the main have been uninsured. Some have come into the insurance market and out, but many of them have never participated in insurance programs before. So they're accustomed to using the emergency room as their primary care source. And all of a sudden, they are going to be into an entirely new world, navigating insurance and doctors in a way they never have. So I'd leave it to the experts like John, but you could have tremendous shifts in utilization as people try to figure out a world they've never been in before.
That's interesting. John, Mike, let me ask you this question, kind of piggyback on that. What will it look like when I walk in to see my family physician 5 years from now?
Well, in Massachusetts has exchanges. They actually call them something different. They call them connectors. But the result of increasing the population of folks who have insurance, which is a good thing, is there was nothing really done with the provider side of things. So there's turning out to be a shortage of doctors. And there may ultimately, and there's also a shortage in waiting hospital beds. So people are having to. It's taking them longer to see the doctor when they want to see the doctor. The waiting rooms, waits at hospitals has actually gone up. You would think that it would have gone down because people have more access to doctors because they have coverage and so on. In fact, that did not change the pattern of behavior for a lot of folks. People who are used to getting their care through the emergency rooms or urgent care centers continue to go to them, and the lines have gotten longer because people can't see the doctors on a timely basis like they're used to. The challenge that people need to think about, in fact, the overall big picture is this, and I'm frustrated that politicians, folks on both sides of the aisle, have not dealt with this in a substantial way. We have baby boomers we're starting to get to Medicare age, and yet on the other side of it, we have a shrinking tax-paying base of folks who are going to be paying for them. Nobody's talking about that. Right now, we've got, for every Medicare beneficiary, 4 U.S. tax-paying citizens supporting them. By the time I hit 65, which is 13 years from now, that's going to go from 4 to 1 down to 2 to 1. And the question is that who's going to be paying for these doctors? Who's going to be paying for these hospitals? Where are these doctors going to come from? And how's this country going to support this? And none of this stuff with the ACA addresses this in a meaningful way, and that's probably one of the most troubling aspects of that, is in terms of a lost opportunity a couple of years ago.
You know, John, I teach long-term care, excuse me, and this is, to me, has always been the elephant sitting in the living room that nobody's willing to talk about, and I think you're absolutely right.
The public talks about Social Security being a drain on the economy when the trust fund runs dry, but the Medicare issue is, by most accounts, a bigger problem. And John's right. Because it is not going to become acute, to use a medical term, for some years now, people can put it off. But it is a ticking time bomb that isn't being addressed.
Exactly. Our guest by phone, John Nelson, president of Warner Pacific, and Mike Belote, consultant to California Health Underwriters Association.
Well, I think you both know that numerous physicians have said that if this bill is approved, they're going to opt out of the system. They're going to just retire or move on and do something else. How are people going to get physician care if we have the reduction in the number of physicians, yet the increase in the number of covered individuals?
Well, from what I've heard from primary care doctors, who've been in the business for a while, most of them aren't happy, and that extends into some other practices, including obstetrics and so on. I mean, they're not all that happy, and surprisingly, large number said had they to do it over again, they would have got into medicine. The key for us is to recognize where the money is going in our system. Right now, healthcare in this country costs $2.7 trillion. We spend more on healthcare in this country than France does in its entire economy. We spend 17% of our GDP on healthcare. It's going to go up to 21% or so in about 10 years. So where is this money going to? Well, I can tell you where it's not going to. It's not going to primary care medicine, and most of it's going into acute care. 1% of the population eats up 35% of medical costs, and a lot of it's because people are not seeing the doctor at an early stage of a chronic illness. And so when things do go wrong, and they do, instead of a diabetic taking care of his diabetes and getting his insulin and seeing a doctor on a regular basis, now we're talking at dialysis at $10,000 a day, a new kidney at $250,000 a copy. It's reallocating resources, putting more money into these doctors who are taking care of us rank and file, making more incentives for them to be primary care doctors. Most doctors who are graduating from med school with $300,000 or $400,000 of student loans have no interest in making $150,000. They have every interest in making 3 times that amount by going to specialty care. We need to address that problem, recognize it, and fix it.
So how do you address it, John?
Well, it's starting to happen. One of the good things about the ACA is that as costs are going up and employers are shifting the cost more towards employees are starting to ask the questions. Why is this procedure so expensive? So they're shopping not only the doctors for cost, but they're also asking questions about quality. And one of the positive things about the ACA is it changed the dialogue in this country. People are starting to ask as a population, why are things so expensive? How do we bend this cost curve down? And how are we going to pay for this thing down the road? People will not be able to count on the federal government to pay for this, especially in light of the deficits we're running right now. The private sector is going to have to bear more and more of the burden. And so people are starting to realize the advantages of primary care. The dialogue is starting to happen. Insurance companies are even starting to incentivize doctors in a different way to help keep them in the business of taking care of people.
What do you say?
I think there will be a huge discussion on the very point John is raising. How do you incentivize medical students to choose primary care over the more lucrative specialties? And I think you'll start hearing discussions about, loan forgiveness, other programs to get people to be primary care docs. Even while other doctors, as you indicated, Clay, will say, I'm out, I'm not going to take Medi-Cal, I'll give discounts for cash for people that just come in and pay for the service. There will be all sorts of reactions now, but we had better find primary care physicians or the system won't work.
No question about it. Let's pick up there when we get back. We'll be back in a moment on Taking Care of Business on Koerner Radio, News Talk 1180.